essential aspects of successful insulin therapy, we have Mr. Om Lakhani. Welcome, sir.
Thank you very much. I guess so. First and foremost, I'd like to thank the organizers for having me. I'm sure all of you would agree that this is an impeccably organized conference, right from the smallest of details, and I think this is really fantastic. And I think Unni sir, for me, is like an idol, a role model, so I think I'm really privileged to be here. Now, I'm going to talk about essential aspects of a successful insulin therapy, the dosing, titration, storage, and the transport. Now, first we'll talk about a different kind of transport. So yesterday, I almost missed my flight because of a patient who actually showed up 15 minutes late for his consultation. He was the last patient of the day. I waited for him because he was a friend of a friend who had, highly recommended that patient that, why don't you see him? So this guy shows up, 35-year-old, works for a mutual fund company. And, he was diagnosed to have diabetes about 2 to 3 years back. Presently, he had an HbA1c of 11. He had symptoms of insulopenia. So he had weight loss. He had, increased frequency of urination. His random sugar was 300 at the time, right? No ketones. So typical, aggressively presenting type 2 diabetic patient, right? So we discussed the therapy options for him. And I told him, boss, the best treatment for you at this point of time is without a doubt insulin, right? So we'll initiate you on insulin. Your HbA1c is high, your sugars are high. There is multiple reasons why you should be on insulin. And I told him, since you're a mutual fund guy, I hope you understand long-term, right? And we talk about long-term management instead of short-term results. And in a long run, you will have less likelihood of developing complications. As studies have shown that early initiation of insulin reduces the risk of long-term complication. What he told me really surprised me and almost made me miss my flight was this, that, he said, who is thinking long-term? Have you heard of coronavirus? We never know. You might die in the next year. Who knows? I'm not bothered about taking insulin, about what complications which I'm going to develop 5 years, right? I'm happy with give me a pill, maybe some diet. I'm happy with that, right? I'm not worried about long-term because, as the markets are showing, you really don't know what happens, right? And he was wearing that, mask, and he was, I'm sure, snickering behind his mask. So I told him, look, this is what clinched the deal. I told him, look, the mortality rate currently with coronavirus is 3%, right? So out of 80,000 in China, 3,000 had died, so close to 3%. But do you know the mortality rate of uncontrolled diabetic patients having coronavirus? That's 9%. So that's 3 times the risk of dying. So while you wear your N95 mask to protect yourself, well, if you do develop coronavirus on your next trip to Pune maybe, your likelihood of dying would increase by 3%, 3 times rather, right? From 3% to 9%. So he thought for a while. I couldn't see his face really behind the corona mask. But next he said, okay, so let's discuss the dosing. So let's discuss the dosing. So, as these halls are named after, Best, Banting, and Collip, and MacLeod, when they came up with insulin, and like any new invention, the first question they asked was, well, we have this, but how much do we give, right? If we give too little, the patient will go back to those, LCHF kind of diet they used to follow that time. And if you give too much, the patient will still go back to that LCHF sort of diet which they're trying anyways, right? So you have to give the right dose, right? And that has always been a challenge. And after years and years of insulin use, we're still struggling with that very question, right? So, to answer this, I looked up at what the industry says, What do these manufacturers themselves say about the dose? So what do the product monographs say? Well, I looked up at Glargine, Lantus, and sorry, it was product monographs, so you had to take the brand names. They say the recommended starting dose is 10 units for insulin-naive patients. For switching over, so if you're switching over from a twice-day NPH-based insulin to Lantus, then you'll have to approximately reduce your dose by 20% to reduce the risk of hypoglycemia. So this is the recommendation from the monograph. We talk about degludec, Tresiba. Again, similar dose has been recommended. So 10 units of starting dose in adult patients with type 2 diabetes. For type 1, you can see that the recommended dose in insulin-naive patients is approximately 1/3 to 1/2 of the total daily dose. When we talk about switching over, again similar, there is reduction of 20% of the insulin which you have to do. So if your patient is on premixed insulin and you intend to switch over to basal insulin, you might have to do a switch over of reduction of about 20%. If you talk about Rhizodec, that is IDEC S part, the newest on the block amongst these, the recommended starting dose, generally as a general rule, they say 0.2 to 0.4 units per kilogram of body weight to calculate in type 1. Though, of course, we don't prefer these insulins in type 1. Whereas in type 2, which is where we prefer it a lot, is again 10 units. So on a whole, you can say most recommendation is 10 units of starting dose of insulin, right? My question to you is, how many of your patients stay on 10 units? That's my argument, right? So the first important take-home message is, if you're not familiar with the insulin, read the product monograph, see what the manufacturer recommends. That is the safest thing to do, right? We don't really try to be, cowboys in a, area which is not our zone, right? So I think we'll stick to the product monograph. But if you are very familiar with an insulin, probably you can take a little bit of more dose, right? So is this starting dose enough? Now, for a long time, this is a question which I am trying to answer myself, right? So I actually conducted a study back when I was a resident in endocrine. What we did was, we did a correlation between the basal insulin dose required to achieve the target fasting glucose and various laboratory and clinical parameters in hospitalized patients. So this was a hospitalized patient. Why hospitalized? Because they were a captive audience for me, right? And this was easy study to conduct. So very simple study. So those patients whose fasting is under control, how much dose of Lantus glargine did they require, and what were the parameters which determined this effect, right? So on an average, the mean dose of basal insulin in this patient was 25 units, right? So remember, the starting dose is 10, but the mean dose is 25, right, in these patients. And the mean dose per kg is 0.14 units per kg. Again, the starting dose is around 0.2, 0.3, 0.4 units per kg. So the requirement is much higher amongst our patients. These are our patients, right, Indian patients. The requirement is much more higher compared to what we start with. So from this study, and this paper is available in IJEM, what we concluded is that amongst the clinical factors, and as easy to understand it is, glycated albumin or HbA1c had the strongest correlation with the dose of insulin required, right? So easy to understand, higher the HbA1c, more the dose of insulin you'll need. And those patients with HbA1c more than 8 had statistically significant higher requirement than those less than 8. What was surprising to us, and which is extremely controversial, and we go back and we actually presented this paper also in Endocrine Society, and this was the frequently asked question, the patients with renal failure, so we excluded patients with those on end-stage renal disease, but the other earlier stages of CKD, these patients actually had a higher insulin requirement compared to lower. And if you see the recommendation, we are asked to start a lower dose of insulin. So these patients are more insulin resistant, and the requirement may be slightly higher. Age, gender, BMI, timing of the dose. So, often frequently asked question, when should you give the insulin, a basal insulin? And the answer is that these did not have any significant correlation. Now, I drew up a very old paper. This is Holman and Turner. Way back, I think this is in 80s. They gave a practical guide to basal and prandial insulin therapy. Why I'm alluding to this is I'll just discuss this. This paper is very beautiful, right? Read this. I mean, there are things about insulin which I did not know, which I learned from this. And some of the, sometimes the information gets lost over a period of time. We assume everybody knows this. And maybe the next generation doesn't really know, right? So in this, these guys actually suggested the dose as fasting, the dose of basal insulin as fasting plasma glucose minus 50 divided by 10. So they said this should be the starting dose of insulin. What is very interesting is that if you see a lot of clinical trials, including the treat to target trials which you have seen over a period of time, a lot of them have used this as a starting dose of insulin. And on an average, let's say, like Uni sir said, the average HbA1c at the time of insulin initiation is around 9 or 10. I'm assuming the fasting sugar is close to 200. Your starting dose of insulin on an average should be 15 units, not 10 units, right? So the requirement anyways is higher, right? So we conducted this study, and this is an ongoing study. I apologize, it's not a published study so far. this is an ongoing study, and we have done an early analysis just to give a glimpse of the study. Right? This is a single center retrospective study conducted at our center. The research questions we are asking are, first is the correction of fasting capillary blood glucose with strategic use of single insulin with OAD enough for achieving target glucose controls using AGP, that is CGMS. So we all talk about fixed fasting first, right? My question is, does fixed fasting first fix the glycemic control of the patient? That's the first question, right? And this is clinically important because we all discuss about initiating basal insulin versus premix, twice a day premix insulin. This is what Uni sir also showed in his slides. The second question, which is again very important, what is the dose of insulin required to achieve stable capillary blood glucose? This is similar to our earlier study, but this time this is in outpatients, and this is based on patients who are taking one insulin with oral antidiabetic, which is very similar to all of your patients, right? This is very typical of what we do in clinical practice. So it's a retrospective study. Now, in this study, the insulin initiation was done as per the Holman and Turner formula, and that's why this formula is important. Fasting blood glucose or fasting FBS minus 50 divided by 10. This was our starting dose, right? Not 10 units as recommended by manufacturer. Now, in some patients, it would have come to 10 units. Some patients, it might have come to 8 units also. Very much possible, but this was the starting dose which was used. What we did was, and this is what a routine practice is, the patient is asked to report the fasting capillary blood glucose with his glucometer using WhatsApp. I'm sure this strategy is very popular, right? I go about talking to other people, and this is what a lot of people do, right? Some people use phone, some people use WhatsApp. The good thing about WhatsApp is you have the back data. So you can look at the data as you go along, right? For phone, you will have to probably check up in your computer or your patient's file to see what the patient is taking, right? But on a WhatsApp, you already have the transcript, and it's a sort of a very nice way of looking at it. We titrated the dose of insulin to achieve the fasting capillary blood glucose to 90 to 140. Again, if you see guidelines and if you see treat to targets, they often go as low as 70 to 90, including some of the recent trials. But what we believe is that on an outpatient basis, using a glucometer, which we really don't know about the quality and all, often a lower titration may lead to increased risk of hypoglycemia, right? So we kept a more lenient target of 90 to 140. Once the capillary blood glucose fasting CBG was within the target range, for 3 consecutive days, we sort of locked down the dose of the insulin at that point of time, called the patient back, and put an ambulatory glucose profile. So it's very simple. You start the insulin, titrate it. Once the fasting is achieved, call the patient back, then put an AGP, right? And if your AGP shows a beautiful graph of everything under control, right? Fine, you have done your job. If not, you see the problem areas, and then you correct the problem areas as we go along, right? So we did an early analysis of 64 patients. This is 64 randomly taken data from the pool, right? And as you all know about law of statistics, anything you take out of a pool, right, it might be representative of the entire sample. Currently, we have around 500 patients data, but we have just taken 64 as a sample analysis. The mean age of this patient was 53. The mean weight was 75. 39% were males, and 10 was HbA1c. 10.2 was the mean HbA1c, and creat was 1.1. So again, we are guilty of starting insulin at a higher HbA1c of 10.2, right, which is a bit of a problem. The insulin which was used in this 64 patients, glargine in 53% of the patient, IDEC aspart, that is Rhizodec, in 42, and Degludec in 5% of the patients. What you can see here is that the mean final dose of Degludec was 23 units, IDEC aspart was 28.4, and glargine U100 Lantus was 30 units. The mean dose, remember, it's the mean dose. The mean dose in outpatient was close to 28 to 30 units. And you see the starting dose, 10 units, right? So it's much higher than what was recommended by the manufacturer. And if you see per unit per kg, it is about 0.2, 0.36, and 0.4 units per kg. We did a univariate analysis. So far, we don't have the complete data for multivariate. So we did a univariate analysis and found that HbA1c and the final dose of insulin had a statistically significant correlation, as we had shown in the earlier study. Now comes the beautiful part. So the answer to the question is, does fixing the fasting with use of OAD successful strategy for your patients? Answer is yes and no. The target was achieved in 81% of the patients on Rhizodec, 74% patient on glargine, and 100% of patient on Degludec, which is beautiful. GMI is basically the one the average sugar which shows on the left side of the AGP graph. It was 117. It's close to an estimated HbA1c. And when you talk about HbA1c of 7, it would come to 154. So in all our patients, the average GMI was 117, 121, and 139, which was very close to the target, definitely less than the target. The time in range, the ideal range is 70%. In most of the insulins, it was achieved. Glargine, it was 69%, slightly lower average. IDEC-aspart you could achieve in 71% of patients. And that alludes to the fact what Dr. Unni sir told you was that, probably use of IDEC-aspart achieves a better time in range compared to those with basal insulin alone. Time above range was as shown, and time below range, which alludes to hypoglycemia, was around 10%, right, in these patients. So again, remember, there is a risk of hypoglycemia, but it is much lower. And these are asymptomatic hypoglycemias. These are not symptomatic hypoglycemia. So in 81% of patients on once daily use of IDEC-aspart, on fixing the fasting sugar is enough to achieve the target glycemic control. This is what an important message I have to drive home, right? We all talk about twice daily IDEC-aspart. I believe in 80% of your patients with strategic use of oral antidiabetics, even once daily use of IDEC-aspart to achieve a target fasting sugar may be enough in 80% of your patients. And remember, I come from Gujarat, which is the highest carb eater in the entire state, right? We talk about carb eating Indians. We are a very high carb eater, and yet we could achieve it. I'm sure it's much better in northern India where the carb content may not be that high, right? So the second important take-home message is, as Holman and Turner says, the formula may actually be more effective, and perhaps the starting dose of insulin needs to be little higher than what we generally do. What about titration? Now, most studies recommend titration of basal insulin, or in fact premixed insulin, to 2 to 4 units, ranging every 3 days to 1 week. The target, as recommended by RSSDI and other guidelines, is 80 to 130. Like I said, we use a target of 90 to 140. I'm sure a lot of people in the audience would agree to me. There's no point of targeting below 90, right? It would be a good idea to stop at 90, and that would be enough in a lot of our patients. This is the consensus guideline for titration, specifically for titration, published in JAPI. And this is the recommendation. Again, the target recommendation is 80 to 130. And they recommend dose adjustment as it is shown in this table. It's a gradient response. What we do is, either me or my diabetes educator adjusts the dose based on the WhatsApp. And often it is of the similar nature, right? So the FFF study, in our study, the insulin dose was titrated daily, not every 3 days. The titration was 2 to 4 units. The target was 90 to 140. Very interestingly, no reported cases of severe hypoglycemia. Even level 1 hypoglycemia was very less, and this was done using WhatsApp. How do you titrate? It could be either patient-based or physician-based. Either you can give a written instruction, so many dose, so much of sugar, you take so much insulin. You could have mobile applications which are now available, but it could be physician-based. Now, if you take studies from the West, most studies from the West say that patient-based titration is as good as physician-led titration. But I really beg to differ. A lot of our patients are not educated, they get confused, they are starting insulin for the first time, they need somebody to hold their hand. That number which you give, right, is a bond which you create between you and your patient. And I think that bond really, that patient is going to ask your advice for glycemic control. He's not going to run away and meet a Baba, right, or a quack, right, because he trusts you, right? That's the bond you should develop. Is this applicable to India? We used a WhatsApp-based titration. So it's very difficult to compare because this is what we do. And this is what we did. If you can see just a sample, we have hidden the name of the patient. The patient's, let's say, on October 22nd, it's 154. You increase the dose to 22 units and so on and so forth. Ultimately coming down to a stable dose where, the range, it stayed within the range and we knocked down to 28 units. So the important message is that titration frequency, as the guideline suggests, is 3 to 7 days. Target, as the guideline suggests, is 80 to 130. Dose steps is 2 to 4 units, and patient-based self-titration is what is recommended. But we actually challenge, since this is an unpublished study, we challenge all these notions. We believe titration needs to be almost daily. The target needs to be 90 to 140. Steps can be very similar, 2 to 4 units. And physician-led titration, in my opinion, is probably, or diabetes educator-led titration is better compared to patient-based titration. The injection technique, I'm sure this august audience does not need to know the injection technique. You are all experts. But I'll just tell you one insight of mine. I often tell my patients, for those whom I initiate the insulin, I ask them to get the insulin, come back to me. I teach them insulin initiation myself. I ask them to take 2 units in front of me. This is my standard policy since the last 2 to 3 years. And I believe that almost my success rate of starting and giving insulin in a proper manner is much better. I don't even leave this to my diabetes educator. I leave it to myself. Because remember, when you're initiating something which is drastically different, which the patient is resistant to psychologically, it's very important, again, to hold the patient's hand. And when you show the patient the right technique, the right way, I think my time is up. I'll just slightly overshoot it, right? If you teach it the right way, it often helps, right? We all know site rotation, technique. You can all go to the FIT guidelines, right? Forum for Injection Technique. Beautifully illustrated guidelines for insulin techniques. One important thing, and again, very important, is reuse of needles, right? And, amongst all the questions which I asked the patient who was already taking insulin about how the insulin is to be taken, there's one issue which was always commonly seen. They did not know that they had to change the pen needle, right? There were patients who told me, I asked them, when do you change your needle? They said, I do it once I run out of my, of the cartridge. Some people say, I never change it. Some people say, I change it every day. There's a variability of thing, right? So I show them this picture, a new needle versus a needle which has been used sec 2, 3, 4, 5, 6 times. You can see the change based on a microscopic picture. And I tell my patients, ideally change daily, right? And I'm sure this should be the recommendation to all. But amongst all the common complications, changing of needle is a common issue. And if not anything, at least ask your patient how frequently do they change the needles, right? This is very, very important. So this is a key point, right? We typically use 32 gauge 4 mm BD needle whenever possible. If you're using a 4 mm needle, you don't need to pinch in adults. You can directly inject, right? This is something you need to keep in mind, and change the needle regularly. Storage. Again, I'll not go too much into it, but unopened cartridges, 2 to 8 degrees is the storage. And in-use cartridges or pre-filled, you need to store it at 15 to 30 degrees. Westerners will say, room temperature. Tell me, after March, how many times our room temperature is 30 degrees? Right? It is not room temperature for us. I'm sorry. 15 to 30 is not room temperature in India. Right? It's a pleasant temperature, not a room temperature. Right? So, need to tell your patients about the proper storage. Right? Typically, we ask them to store it in refrigerators on the side compartment. Don't freeze it. Pens are stored without the needle cap on. Right? Don't keep the needle on. Right? This is important because it can sometimes lead to clogging, and thermoinsulation can leak. Right? And I think an exam question asked in for both MD and DM residents is that what happens if your patient doesn't have a refrigerator, if doesn't have electricity, doesn't have this, doesn't have that? The answer is they can store it in an earthen pot or matka with water, which I'm sure keeps the temperature 15 to 30, right? The average shelf life may differ based on the insulin which you're using. On an average, it's 28 days. Please make sure that the insulins are discarded in a proper manner. Transport, of course, extreme temperatures should be avoided. Now we, of course, have cars with cooled glove boxes. But patients often keep it on the top where the sunlight exposure and there's a sort of greenhouse effect which happens, and their insulin is typically ruined, right? They can keep it in handbags, flasks, or special pouches for this purpose. And during air travel, frequently asked questions, right? Air travel, it must be in the hand luggage, not in the storage compartment, right? So this must be kept in mind because you really don't know what's the temperature exposure at that part, right? So store unopened supplies at 2 to 8 degrees. Open supplies at 15 to 30 degrees, and the time period of, the discard insulin after the time period specified by the manufacturer. So I'll just summarize. Read the product monograph. Probably use Holman and Turner formula for a higher starting dose of insulin. Titration is as guidelines suggest, 3 to 7 days, every 3 to 7 days, 80 to 130, 2 to 4 units, and probably patient or physician-based titration. Rotate your site, use 32 gauge 4 mm needles. You don't need to pinch there, and change the needle regularly. And store it at 2 to 8 degrees, unopened, open cartridges at 15 to 30 at the time period specified by the manufacturer. Thank you.
Thank you, Dr. Om. I think we are open for panel discussion.